Hello everyone, this is Chadi Alraies from CVI 2022 in Denver, Colorado. I'm really privileged to be with Dr. Gaffer Golzar, who is an interventional cardiologist at Advocate Christ. Gaffer, always nice to see you.
Thank you so much. It's always a pleasure to be around you, hang out with you. You've always done some phenomenal things, and you're really one of the leaders in the social media world, so it's always a pleasure to hang out with you.
Thank you, Gaffer. And as an expert in peripheral intervention, and you have innovative too much into CTO and the peripheral sphere as well as atherectomy. You gave a talk about pedal access.
Yes.
So this is kind of becoming a new thing and more acquired things. Been there. Tell us about new innovation and what's your access and what's your approach to this?
Yeah, I think the biggest thing is you really ensuring that people use it. And that's the thing, is people are just so intimidated by pedal access because they feel like it's exotic. We shouldn't be doing it except for if you're doing it for really complex end-stage patients. But I kind of think about it as a radial artery of the foot, Mm-hmm. And so from my standpoint, it's like, use it often, use it frequently, and start mastering that technique. Because if you just use any technology or technique in that end-stage person, then you're going to fail a lot, because you already have that selection bias.
Correct.
So use it often. And so we have these tips and tricks, of what we're trying to kind of talk about for being able to have good success with these pedal access.
Yeah. So when do you select pedal access? When do you say, this case is a pedal access?
Yeah, good question. So there's two different things. So first of all, we want to make sure that we're ready for pedal access if we need it, because you don't know when you may need it. So you could have a 30 millimeter CTO, as that you can go subintimal, or you can have a 400 millimeter CTO that you cross just like that. So you never know. But if you're not ready with pedal access, then you know how it is. You can tell the cath lab and say, oh my God, you got to prep the foot now. And so we're like, just go ahead and prep it, and it's ready for you. But then there's some select cases that we're like, there's no way I'm crossing this antegrade. So heavy osteocollateral, heavy collaterals from the proximal cap, you're not going to be able to cross. Or let's say if it's a stump occlusion in the SFA, you go steep osteo, and like, there's no way I'm going to get into anything. We go immediately. So those are sort of the couple that we almost automatically just go ahead and start with, but then everybody else we just prep.
Yeah. So in terms of sheath selection and catheters length, especially in average to tall patients.
Yeah. That's a really good question. So, it's not controversial, but everybody has their own technique. So from my standpoint, I like bareback. I like minimize my pedal access time. I don't put in a sheath. I just use the O&A quick cross, or any other Trailblazer or something like that, and just go and just try to minimize my pedal access time, and then just reverse everything and go antegrade. But some people use the sheaths, and there's a slender sheath that's really good for pedal access. So regardless of the technique, I don't think there's any right way. I think that it's more about particular preference in terms of using sheathless or just working fully retrograde. I don't like to work really fully retrograde. I'd like my whole point of going retrograde is to reverse and go antegrade wire access so I can work antegrade.
So when you say reverse, you mean you go axial retrograde, you cross the CTO, and then go contralateral up and over?
Well, no. Most of the time I like to have antegrade access. So let's say if I'm going below the knee, I'll have antegrade. But let's say if we're SFA and we're contralateral, so what I'll do is, we'll get retrograde, we'll cross, and then I'll either externalize my wire with a with an end hole catheter or with a snare. Try to not, avoid snare as much as possible. But I will put in a little plug. So we do have a new wire coming out. We just got a patent on a wire last year. It's a double-ended bilateral breakable tip wire. So it's going to decrease pedal access by about 40%. The time for that, because you can snare that wire, pull it back, and instead of having a sharp tip at that back end, you have a soft tip. So now you can just advance that soft tip, and then you just break your other wires. So
and advance your balloons over.
Yeah, through that. And so that's a Scorpion wire that's going to be coming out hopefully by next year.
Nice.
So it'll kind of improve that.
Yeah, atherectomy, you can use everything through pedal, no problem.
Sure, yeah. Atherectomy through pedal you can. A lot of people do orbital atherectomy. Even sometimes they do directional atherectomy with a 6 French sheath. I prefer not to. I like to do most of my work from antegrade. So, but if I absolutely have to do it absolutely, no problem at all.
One question about preloading the patient. How often do you use CTE abdomen pelvis with distal runoff? How
Good
often do you use it
question.
in practice?
Good question. So, imaging is important. I think it's very helpful for case planning. I think, from my standpoint, you have to be very careful. So when you're doing ultrasound, look at your ultrasound yourself, because very often what you'll see is, and I think some of our podiatrists and primary care physicians, they get fooled by this as well. They'll look at the ultrasound and they say, oh, mild to moderate disease, but then you'll look at waveform, says monophasic. So first of all, look at it yourself. So if we do ultrasound, we're doing it in our own office so we can at least see it ourselves. And really it's for case planning. And what I want to know is not that is there disease or not, because if there's gangrene, I need to do an angiogram, no question. The question is am I going to go antegrade or am I going to go crossover technique? And so it really helps, because I prefer going antegrade, because as you know, improves your wire torqueability, pushability, trackability, and so I prefer it. But if it's an osteal SFA or mid SFA, I can't go crossover.
Awesome.
Antegrade.
Well, Jaffer, this is phenomenal
Thank
tips,
you.
like in a very short 5 minutes.
Thank you so much.
Course about
Thanks for the
fetal access.
opportunity. I appreciate it.
Thank you so
Thank
much,
you.
Jaffer, again.
Appreciate it.
Please watch this video and others on CVI YouTube channel. This is Chadi Alraies from Denver, Colorado. Jaffer, thanks again.
Thank you so much. Appreciate it.